For months now, menopausal women across the country have been unable to fill prescriptions for a hormonal therapy patch. To tell us more about the shortage, we have via Zoom Dr. Suzanne Gilberg. So let's talk about whether there really is a need or a loss of being able to get these hormone patches, or is it manufactured?
Well, I mean, I can't speak to whether or not it's a manufactured shortage, but it is definitely, there's a shortage. I mean, people cannot fill their prescriptions, and it's a bit of a game of whack-a-mole because people are going to local pharmacies, then they go to online. I mean, it kind of keeps expanding, and now there are reported shortages in certain areas of not just the estradiol patch, but also the progesterone that is necessary to protect the uterus. Vaginal estrogen cream, estradiol cream is now reportedly in shortage. So I don't manufacture these things, so I can't tell you if it's the origins, but I can tell you what my suspicions are around that.
Please do.
Yeah, well, I mean, so I wrote an op-ed that was published by the LA Times a couple weeks ago with my wonderful colleague Jennifer Weisswolf, who's a law professor at NYU and runs the Women's Health Policy program there. And really, what we think it comes down to is the verticalization in the healthcare industry, specifically when we're looking at pharmaceuticals. So a lot of people don't understand how this works. You know, your doctor writes you a prescription after you've had a consultation with her, you've come up with a plan, and you think you're going to be able to go and get that medication filled, in this case, hormone replacement therapy. But it's much more complicated than that because the supply chain is not the only issue. It's not just the manufacturing process. It's also the process of how these medications get into the hands of the patient. And there are multiple levels. So we know that almost 80% of pharmaceuticals are controlled in terms of how they are distributed by a vertical process. There are 3 companies that own the majority of the pharmacies and something called the pharmacy benefits manager. So I know this is getting into the weeds, but it's really important for people to understand the pharmacy benefits managers, the PBMs, are middlemen, and they negotiate between the pharmaceutical company that manufactures and the insurance company that sets the prices, and then the pharmacy itself. And almost 80% of all of this is owned by 3 companies in the United States, which is a monopoly. So when you have a medication that is generic and been around a long time, like the estradiol patch, and has a very small profit margin because they can't make very much money on it, and it's not super difficult to make, but it's not as easy to make as other things. You can do the math yourself. There's not a lot of reason for these companies to favor making these medications, despite the fact that they are necessary medications for a lot of women. The story that we've been getting told is that all of a sudden there is a huge increase in demand because over the summer, the FDA approved removing something called the boxed warning on the label of some of the estradiol products. And so now they're saying there's a surge in demand, and that's not accurate. That's not accurate. We know that the only between 2 and 5% of American women who are eligible to be using this medication are using it. So it's not a surge in demand. It's probably a byproduct of people really not making enough money off of this and not favoring or really centering or prioritizing women's health.
Yeah, it seems as though it might be a combination of both, right? That the profit margin is not so large. And secondly, historically, women's health issues have not been treated the same as men's. Would you agree with that assessment?
I would 100% agree with that assessment. I was in medical school when the FDA started to require women be a part of clinical trials. I'm going to say that again. Until I was in medical school, women weren't even required to be a part of clinical trials. What does that mean? That means that any medication that is out there that's being used prior to 1992 or 1993 wasn't required to be tested on women. We're over half the population. So, I mean, I could dip into a lot of different statistics that will point to exactly what you're saying, but we have lots of evidence to support that women's health is not considered important. We're not the norm, which is bizarre. Like we're 51% of the population. Why are we not the norm? I can go into NIH budgets. 11% of the National Institute for Health budget is devoted to all of women's health, all of women's health.
So what can women do? What can patients, doctors, what collectively can be done?
We can do this. We need to talk about and name what is actually going on. So this whole narrative over the last couple of months around the shortage being blamed on women. You're asking for too much. You're too much. You all of a sudden now you all want this. We have to point out that that is not accurate. We are not too much. We are just trying to exist and live. And we deserve the same kind of health care that every other human on the planet deserves. So we have to first understand, we have to educate. And that's why I've been so out front about this as a physician, because I understand the system better than a lot of the patients do. That's number one. Education, communication is number two. Alliances. The alliances that will change the way healthcare is delivered and paid for are going to be between patients, practitioners, and policymakers. And so we're starting to see that happen, which actually is very positive. If you look specifically at menopause, menopause was something we weren't even talking about very much a couple of years ago. It's all over the place. It's all over social media because the population, the women, the practitioners want and need this information. It represents 20 to 30 to 40% of a woman's life, and it is an important time for us to be aware of our health span, our needs, our longevity, our productivity, our joy, our peace. We are here to help and be a part of the community. And so we deserve more. When we understand that and we partner together, we can get loud and we can make noise. And we're seeing that policymakers are embracing this. We're seeing in many state legislatures, people coming together to make changes in terms of education and laws that are affecting our women's health. So I'm weirdly hopeful, but I do think that the corporatization of healthcare has been probably the worst thing to happen to our health and to women's health, and we have to continue to call that out and name it.
Well, doctor, how do you think you can fix it when the system really hasn't been designed for reimbursement for women for hormonal care, which I think in itself is either ageist or sexist or possibly both?
It's probably both. It's probably both. And, here's the problem. The system is quite broken. And again, this is an area that I think that people even inside the system don't understand how it works very well. Certainly the patients don't understand how it works at all. My solution, to be perfectly honest, was to pull outside of the reimbursement system. I left a large practice. I was a partner for over 20 years in a practice I was quite proud of here in Los Angeles. And I left because I could not get reimbursed for time and expertise. Reimbursement systems value volume and procedures. And there's even data to demonstrate, once again, sexism and ageism, that if you like head-to-head compare procedures that are done on women versus men. So there are lots of studies looking at like urologic procedures in men and the analogous procedure in gynecology, and the reimbursement is totally different. Women's health procedures make way less money. They're valued differently. So I just said to myself, I can't take care of my patients in the way that they deserve, in the way that I want to practice. And so I no longer take insurance. And that's what Monarch does. We help doctors move into membership-based practices that serve midlife women's health, which is a very underserved and very important moment in a woman's life. So that's been my solution. And also to be out there now, because I have more time, and be advocating for change, educating people, communicating this information so that we can come together to find a better way to care for ourselves. Because the current system, like you said, it just doesn't value and this isn't just in women's health, by the way. This is any chronic disease that requires a lot of back and forth, a lot of conversation, a lot of tweaking. That's not valued. That, you make money by seeing a lot of patients for a very short period of time, and that's not, in my opinion, the way to do good health care.
Do you think there's a possibility, because of all of the negative publicity around hormone replacement, do you think that factors in at all?
Yes. I mean, I think if that, in terms of the policy decisions, I don't know. I can't speak to what they're doing and what their motivation is really. I can just name what I see. I will say we know that women's health has suffered in the years since the Women's Health Initiative. The Women's Health Initiative is an incredible, incredible study that really looked at data in a very interesting way. But is it the be all and end all? No. And there was a lot of misinterpretation and misinformation propagated from this study, specifically around breast cancer risk and hormone replacement therapy. And so for 23 years, women were scared to use hormones, and a lot of physicians were scared to prescribe hormones. So we saw that in the early 2000s, when this study came out, over 40% of women in the United States who were eligible to use hormone therapy were using it. That number shocks people. We're now at about 4 to 5%. So did it scare people off of using it and scare people off of prescribing? Absolutely. But is that like the motivation for not producing it? I mean, again, these medications are old, they're generic, they're inexpensive, they don't have a high profit margin. And, companies are there to make money. I understand that. But Viagra is really cheap. Have you ever heard of a Viagra shortage? Because I haven't.
Well, you make a good point.
Yeah.
A question, because I read about you're doing menopause boot camp. What exactly
Yeah.
is that?
Well, I mean, menopause boot camp was something that I started doing here in Southern California probably, oh my gosh, 8, 9 years ago, partly because I was really doing a lot of menopause care. And I found that my patients didn't have enough time to get the information they needed to understand what they were facing and what they could do. And then also, I do a lot of writing and teaching and public speaking, and people were always asking me these questions. And I said to myself, I got to do something. And I literally just made it up. And I just started doing these small events where I was teaching people about menopause, the terminology, the impacts on your health, the solutions, the problems. And, really, it was very interesting. I thought I was doing it for educational purposes. And what I realized was that I was creating community. And then we had the lockdown, right? And we had COVID, and everybody wound up online and everybody was talking about this. And somehow menopause kind of exploded. And I was already working on a book. The book was published based on the boot camp itself, called Menopause Boot Camp in 2022. And the next thing I knew, everybody was talking about menopause at the same time. It was the zeitgeist. And it's been remarkable because in a very short period of time, we've really made great inroads. And I think a lot of it is because of the media's picking it up and seeing like this is important. We need to talk about this. We're not going to do one segment a year on menopause and we're done, because that is something that was said to me in the past. And I think people's conversations online have been really enormously impactful in terms of spreading information and not feeling so alone. So I'm excited to see what comes next.
Well, speaking of, you're very out there on social media and platforms that put you out there. Some people would say that perhaps that's not the role of a doctor, or perhaps it's not in your best interest. What would your response be to them?
Well, clearly I don't agree. I mean, I'm here for it. Here's the deal. Part of being a physician, in my opinion, is educating, communicating, and advocating. And what better way to do that and reach people that would never be able to see me in my office because they live in a remote location or they can't go to a membership-based, practice. What better way for me to reach a large number of people than to be on social media? And I think the fact that, like, my own personal opinions and thoughts, which I researched really well, I wrote a Substack about it, and then got together with Jennifer Weiss-Wolf, and the LA Times agreed, hey, nobody's talking about it from this perspective. A doctor understands and has an insider perspective into not just the science and your health, but the bigger picture of the delivery system. And so to me, it is part of my job. Part of promoting your health is promoting your educated decision making around that. I feel honored to do it. And if people don't like it, that's cool. I'm menopausal. If you don't like me, it's not my problem, it's yours.
Well, I mean, let's talk about that just quickly. If you could tell us, is there life during and after menopause? Because a lot of women feel as though their lives are over, and maybe even their husbands kind of make jokes about it.
Yeah.
What do you say to them?
I mean, listen, the menopausal transition is not easy. It is not for the faint of heart. But it's much harder when you're not educated. And that was a big reason why I started doing these boot camps and writing and teaching about it, because I know my own experience of going through things. And I'm an educated person. I'm an OBGYN and a menopause expert. And my perimenopause was not easy. It was not fun, a lot of it. So I understand that. But when we are in community and when we have the support and the resources, we can do lots of hard things and we can do anything. And listen, what really most great things don't just plop on your head. They are born of a challenge and a struggle and the growth that transition helps to promote. So for me, there's definitely life after menopause. I'm literally living my best life. I'm my most creative. I'm having impact in a way that is joyful and fun for me. I'm making choices that I appreciate. I say no, I say yes. And I mean, here I am having this great conversation with you. Getting through it is not so easy. So I don't recommend you do it on your own. I recommend you get help and you talk to your friends, you talk to your community members, you find physicians and clinicians that can support you on the way. And also, I mean, listen, for the men, even if you're not in a relationship with a woman, there's no man that isn't going to be touched by this either. So educating our men, I have a son, he knows a lot more about menopause than the average bear, I'm pretty sure. The men in my life know a lot more about. My brother sends me stuff about menopause all the time. We can have a positive impact when we share our struggles together and we support each other. It's a natural part of life. Like we call it the puberty of midlife for a reason.
All right. Thank you so much, Dr. Gilberg. For more on her organization, log on to monarch, right, md.com. We thank you for your time today.
Thanks for having me.